What I want to talk to you guys about today is pretty much what it is that we do in the EP lab, the treatment of atrial fibrillation, how much it has changed today compared to 10 years ago, and why it is that today there's people specialized in atrial fibrillation only. So AFib, there's an explosion in the incidence and prevalence of AFib in the US. And it is a disease that affects more elderly people. However, overall, there is for all ages, there's a significant increase in the incidence and prevalence of AFib. So right now it's estimated that we have about 3 million people with AFib, and some estimates will say that by 2050 we'll have 5 million, but some studies have shown that we probably have about 16 million people with AFib. So there will be a lot of patients with AFib for us to take care of in the future, and 5 Main will be busy. AFib is very expensive to healthcare. It's one of the most expensive diseases. It's a significant burden to Medicare. So the average hospitalization is about 5 days when someone is admitted with AFib with rapid ventricular response, for example, with an average cost of almost $20,000. This does not include the procedures I do, doesn't include drug side effects or strokes related to AFib. So estimated burden, not counting those important things, is about $16 billion. So when you see someone with AFib, the right thing to do is, when it's first detected, is to determine if that patient has what's called paroxysmal, permanent, or persistent AFib. So someone with paroxysmal AFib has spells that will typically last a few hours, but it could be seconds to a few hours, and will stop on its own. This is typically seen in younger, healthier individuals, and with not as many comorbidities. So this would be someone who may have, for example, what we call lone AFib, where it really doesn't have any other healthcare problems at all. Persistent AFib is when you go into an episode of AFib that the only way to stop it is either by drugs or cardioversion. So these are patients that are typically overweight, high blood pressure, diabetes, are comorbidities that we see associated with. And someone with permanent AFib is someone that you've given up already trying to treat the AFib, put them back in normal rhythm. There's nothing you can do at that point. So when I see someone with AFib, the first thing I typically do is try to understand why that person has AFib, see what other diseases the patient has or comorbidities. And many are tightly related to this. As you know, thyroid disease, especially hyperthyroidism, can cause AFib. Alcohol consumption, both chronic alcohol consumption over years, as well as acute, so alcohol intoxication causes what we call holiday heart syndrome, where people drink a lot over the weekend and they come here on Monday with AFib. Cardiac surgery, about a third of the patients that will have bypass will develop AFib, and half of the patients that have some sort of valve surgery will develop AFib as well. Heart failure is, it's hard to know what came first. Some patients' heart failure will cause AFib, some patients' AFib will cause heart failure. We know that the two conditions feed off each other, so it makes it much more difficult for the patient and difficult for us to treat. WPW is associated with AFib as well. And really the most important one in the US is hypertension. So this is a list. It's long. There's many conditions that are associated with AFib. And perhaps one that we have now identified as the most important one is obstructive sleep apnea. So obstructive sleep apnea only recently was identified as a risk factor for AFib. If you have sleep apnea, it makes you much more prone to developing AFib, and it makes AFib much more difficult to treat. So this is a study that looked at patients that did not have sleep apnea and patients that had sleep apnea. And as you can see, those with sleep apnea developed AFib at a much higher incidence than other patients. And it's difficult because sleep apnea, it is difficult to treat. Although we use CPAP, we don't really know how much CPAP helps. The best thing is always to weight loss, which if it helps the obstructive sleep apnea, will help AFib as well. Then the next step when you see someone with AFib is to always think about stroke prevention. So if someone has AFib, they're going to die because of the AFib. It's going to be because of a stroke, a large stroke. So to talk about stroke prevention is really the most important thing when I see someone with AFib. Patients with AFib have a 5-fold higher increase in the incidence of strokes. And why do they have strokes? Because of the left atrial appendage. So clots can form inside the left atrial appendage, and if they dislodge, they can go to the brain and cause really big strokes. The strokes by AFib, caused by AFib, are typically the largest strokes we have. There's about 500,000 strokes per year in the US, out of which 20% are ischemic strokes, secondary to atrial fibrillation. And as you can see, this is the age groups, the older groups. This is a proportion of strokes that are caused by AFib. So if you have someone about 80 to 89 years of age, about a third of the strokes are caused by AFib. This is very important because, as you know, it's very common for physicians to look at a patient and say, oh, he's 85, he's high risk for a fall, and will not give anticoagulation. And that is exactly the population that needs anticoagulation the most. So you have to be very careful with this whole concept of contraindications for anticoagulation, because you can really be withholding therapy from the people that need it the most. So this is what the left atrial appendage looks like, and if you look at it, it makes it easy to understand why people have a stroke. So this is in the left atrium. It's the anatomy of the left atrial appendage is very complex. It has all this different pouches and areas that don't have good blood flow during AFib, where blood clots can form and you can have a stroke. This is a transesophageal echo showing a really large clot inside the appendage, and you can imagine how if something like that dislodges and goes to the brain, it's a disaster. This is another transesophageal echo. The left ventricle, left atrium, mitral valve is here, and you see a large clot at the mouth of the appendage there. Another one. And this is what strokes caused by AFib typically look like. They're really large strokes, wipe out a large area of the brain. So what are the risk factors for stroke when you look at someone with atrial fibrillation? We have what we call major risk factors and other non-major risk factors. The major risk factors are prior stroke. If you've had one, your risk of having another one is very high. A prior TIA, and age greater than 75. The other important risk factors are CHF, hypertension, diabetes, age 65 to 74, female sex, and vascular disease. So if you just ask yourself, of the patients with AFib, you see how many don't have any of these risk factors. Very close to zero, right? The vast majority of our patients we see here admitted with AFib, have many of these risk factors. And what that tells you is that pretty much all of them should be on anticoagulation. So one of the things we use to decide if someone needs anticoagulation is what's called the CHADS-2 risk score. It looks at all of the risk factors we talked about, and you assign a score to each patient, and based on the score, you know what the risk of stroke is. So again, the score is going to be based on heart failure, hypertension, age greater than 75, diabetes, and 2 points for stroke. Someone has 0 points, what we would call lone AFib. The risk of stroke is not zero, but it's about 1.9% a year. And because the risk of bleeding from blood thinners is about 1.5% a year, we say that these patients don't have to be on a blood thinner, but rather just an aspirin will be okay. Patients with one or more, we typically will treat with blood thinners. And going back here, one important thing to look at is, okay, let's say someone has 3 points. This person has, let's say, high blood pressure, diabetes, and is 75. So typical patient that we will see. Someone with 3 points has a yearly risk of stroke of 6%. Imagine how high that is. I mean, you're talking about another 10 years of life, there's greater than 50-50 chances that that person will have a stroke. Someone who's had a prior stroke now has 5 or 6 points, annual risk of stroke of about 18%. So this is how high the risk of stroke can be in someone with atrial fibrillation. There's another risk scoring system that I typically used, more commonly used, which is called CHADS-2 VASC. And for that scoring system, the difference is only that it uses female sex, a history of coronary artery disease, and age between 65 to 74. So remember this, just being a woman puts you at a much higher risk of having a stroke when you have atrial fibrillation. We don't know why, but what that entails is every woman age greater than 65 who has AFib should be on a blood thinner. What the big problem with treating and preventing stroke for patients with AFib has always been Coumadin itself. As you know, Coumadin is very difficult to use, very difficult to keep patients on that drug for a prolonged period of time, and very often people come to the hospital and their INR is what, 1.5, 1.2, it's all over the place. So Coumadin has always been the big challenge in stroke prevention. And the other problem is it prevents ischemic strokes, so it prevents blood clots from going into your brain, but what's the worst side effect Coumadin will have is it can cause hemorrhagic strokes. You can have a brain bleed. So Coumadin is far from perfect. And this is the statistic behind Coumadin. If you have 51 ischemic strokes per 1,000 patient years, Coumadin is going to prevent 28 strokes, ischemic strokes, but it's going to cause 11 fatal bleeds. So the trade-off is pretty high. Aspirin is going to prevent 16 strokes. So Coumadin decreases your risk of ischemic strokes, blood clots going into your brain and shutting off circulation to a part of your brain by about 60 to 70% compared to no treatment, and about 30% compared to aspirin. This is a study that looked at patients that were on Coumadin and were admitted with a stroke. And what you see is the vast majority of the patients, about 80%, had a low INR. There are other studies that have shown that patients that are taking Coumadin, only about 30% of the time, they are actually well anticoagulated, have an INR between 2 and 3. So in other words, you're giving a drug that people will stop because they don't like it, and also that even when they are taking, oftentimes the INR is not a target, it's not a goal, so you're not really protecting patients. Fortunately, we now have the 3 new blood thinners, Pradaxa, Xarelto, and Eliquis. They all work a similar way. They're all very effective. They're all better than Coumadin in terms of decreasing the risk of complications and, most importantly, hemorrhagic strokes. So when compared to Coumadin, all 3 of these drugs were better. That's why the only patients I have that are still taking Coumadin are patients that literally, unfortunately, could not afford the new drugs. But if someone can afford the new drug, they should be on one of these drugs. There's no question that they are all 3 of them are better than Coumadin. One of the concerns with these drugs, though, is that if you have bleeding, you don't have an antidote. You don't have a way to reverse these medications. However, the truth is, when you compare it to Coumadin, there's this common idea that if you give vitamin K, you're reversing. When you give vitamin K, it takes 12 hours for it to reverse the Coumadin effect. So it's not quick either. But there are antidotes being tested right now for this drug, so hopefully soon we'll have them available. What are the contraindications for bleeding? And remember, most of these are relative. That's why the recent fall, the frequent fall, you have to be careful about not withholding Coumadin from someone because they are perceived to be high fall risk. But the real contraindications are bleeding, hemorrhagic strokes. Some patients, unfortunately, frequent falls will get to that point, low platelet count, and recent surgery. Now, with the therapy, where the therapy is going, hopefully soon patient's choice will be as well. And why do I say that? So at this point, what can we do and offer to the patients that cannot take oral anticoagulants that are at risk for stroke, or patients that do not want to take oral anticoagulants? So if we talked about strokes coming from the left atrial appendage, if you think about it, we could close the left atrial appendage and that would eliminate the risk of stroke caused by clots forming there. And that's where procedures are going now. So we have many procedures either being tested or already approved to eliminate the left atrial appendage, either by closing it from the inside or by tying off from the outside. So this is what we call the WATCHMAN device. It should be available pretty soon. The Lariat device, it's a procedure that's already available. I've done a few here. And all of these procedures are aimed at closing the appendage. So just for you guys to understand the Lariat device, first thing is what's called the pericardial axis. Go to the outside surface of the heart. This is a transeptal axis, so the catheter is inside the left atrial. And when I inject contrast, you can see the left atrial appendage here. Put a magnet at the tip of the left atrial appendage from the inside, another one from the outside. They kind of kiss each other, and over that magnet deliver the Lariat, which is the suture. And when we do that, you can compare here before, where the large appendage is over here, and after, all you see is a little nipple here of where the appendage was, so the appendage is completely gone. This is the transesophageal echo of the same patient. You have a large appendage here, here completely obstructed. So this is one of the options for the patients that cannot tolerate blood thinners but are at risk for stroke or have had previous strokes. Now, the new device, what's called WATCHMAN, is a device that from the inside of the heart we deploy this umbrella-like thing. The patients will stay on blood thinners for a few months until endothelium grows over this umbrella. And at that point, no more blood clots will be formed from the appendage. The appendage is completely closed, and then you can stop anticoagulation. This device, what's different from this compared to the WATCHMAN is, whereas the WATCHMAN we used as an alternative for patients that are really have bleeding problems and stroke risks. So for example, the typical patient I have implanted the Lariat is a patient who's had many GI bleeds and they stopped anticoagulation and then the patient had stroke. So that patient is really, there's no options. The WATCHMAN is going to be different. The WATCHMAN is a device that was tested for patients that could take blood thinners but didn't want to take blood thinners, so they were randomized to either this device or Coumadin. And the results were that patients did better when they were actually on the WATCHMAN device. So when you look at the CHAD score of the patients that were in this trial, you see that patients of all CHAD score were randomized. So they really studied very well this across all patients groups. And the results were that patients did better on the WATCHMAN compared to taking Coumadin. Why is it? Because patients on WATCHMAN device, there was no incidence of fatal bleeds. No one had a fatal bleed. You didn't have a hemorrhagic stroke. Didn't have severe GI bleeding. So essentially the complications from being on anticoagulation from long term is what caused the WATCHMAN to be a better device. So as far as the left atrial appendage closure, we have now clinically available, the only option is the Lariat. Hopefully soon we'll have the WATCHMAN. The Lariat, I'm always going to use this as an alternative to patients that really don't have an option. They have complete contraindication to oral anticoagulants. The WATCHMAN, when we implant it, the patient has to be on anticoagulation for about 2 months, and then we can stop it. And this may become first-line therapy, where at a certain point we may offer patients, do you want to take a medication or you just want to have this device so that you don't have to take it forever. Now, one thing that I find more important about anticoagulation when I'm talking to folks is that most healthcare workers don't really have a great understanding of what to do with anticoagulation long term. What do you do if your patient is back in sinus rhythm? Do you stop the drug? Do you continue the drug? Your patient still needs anticoagulation, so what about after a cardioversion? And you see this all the time, where physicians will do a cardioversion and a few weeks later stop anticoagulation. Is that correct? Well, the short answer is no. So the AFFIRM trial is a trial where they looked at patients randomized to either rhythm control, they would shock and give drugs, amiodarone, sotalol, flecainide, or rate control, just leave the patients on Afib and prevent strokes by giving drugs. So in the WATCHMAN trial, in the AFFIRM trial, patients did better when they were on the rate control strategy. And if you look closely, the reason for that is because the group of patients that were on the rhythm control strategy, they had a much higher risk of having strokes. And why was that? It's simply because physicians were stopping anticoagulation. They would shock the patient, a few weeks later stop anticoagulation because they would think, well, the patient's back in normal rhythm, really doesn't need anticoagulation anymore. And you can see here that on this trial, on the rhythm control, 55% of the patients were off anticoagulation as opposed to 32% on the rate control. So what this told us is that once someone has AFib, the cat's out of the bag. It's over. You need to be on anticoagulation forever if you have an indication. If you don't have any risk factors for strokes, you can stop anticoagulation. But someone who, I do a cardioversion here, has high blood pressure, diabetes, it doesn't matter if they stay in normal rhythm for 2 years. They need anticoagulation forever. When I do an Afib ablation, if they still have high risk for stroke, am I going to stop anticoagulation? No. The reason for that is because people could be having silent episodes of Afib. They could have a 1 hour, 2 hour episode of Afib at night that we don't know, and they could have a stroke from that. So once you start anticoagulation, unless there is a contraindication or unless they don't have to be on it forever because they don't have many risk factors, or unless they have an appendage closed, anticoagulation is a lifetime deal. Okay, so we've talked about the comorbidities, the stroke prevention. Now we'll talk about treating the symptoms of atrial fibrillation. So when I see someone with AFib, the first step is to prevent stroke. We're going to use either aspirin or blood thinners. And the second step is to decide if we're going to do rhythm control or rate control. Rhythm control means we're going to do whatever it takes to try to get that patient back into normal rhythm, either by doing drugs or cardioversion and drugs, or by doing procedures. Rate control means we're just going to leave that patient in AFib forever and give drugs to slow down their heart. So for example, give beta blockers, give calcium channel blockers, things like that. And how do we choose? If someone has no symptoms from AFib, it's okay to leave them in AFib. And for those patients, we might choose rate control. If someone has symptoms from atrial fibrillation, then you should try to keep them in normal rhythm. So it's very easy for, if you have someone with paroxysmal AFib, right? Paroxysmal AFib, they're in and out. The patient can tell you, well, and I'm in AFib, I don't feel good, I have all the symptoms. So it's very easy to decide. So for those patients, rhythm control is indicated. If someone is stuck in AFib, persistent AFib, how do I tell what to do? I mean, what's better? Rhythm control or rate control? They don't have a frame of reference. So that's why oftentimes I'll cardiovert these patients. I cardiovert them knowing that the cardioversion will fail. Cardioversion is never a permanent fix. But when I see them back in clinic, if they tell me, well, cardioverted me, and for the 2 weeks after the cardioversion, I felt great, I had more energy, it tells me that, well, we should do whatever it takes to try to keep them in normal rhythm. So maybe do an ablation, maybe do medications. And so this is how I decide who has an ablation, who stays on drug only, who will just be on a rate control strategy. Again, for rhythm controls, we have medication, cardioversion, or ablation. So this is how the old teaching of AFib was. You know, AFib is just this disorganized, chaotic activity in the left atrium. And fortunately, we now know that it's not quite like that. This is the first study that really changed things about the therapy, how we treat AFib. So what this was, in this study, they looked at patients that had frequent bursts of AFib, paroxysmal AFib. They did an EP study, put catheters inside the heart, and by mapping inside the heart, they found that the pulmonary vein, when the patient was developing AFib, the pulmonary vein would start firing electricity very, very fast. And essentially found that what we call the triggers for AFib, what was triggering AFib, was coming from within the pulmonary vein. So this kind of changed everything, because if we now know that AFib is initiated by these triggers, why not trying to eliminate the trigger? So that's how the idea of this procedure we do today, Afib ablation, that's how this idea came from, by identifying that this was all coming from the vein. In the initial procedures, they would put catheters deep in the vein, find the area that was firing, and cauterize that area. That caused problems. It caused what we call pulmonary vein stenosis, where those branches would shut down and patients would get short of breath. That's not how we do now. The procedure is done today, what we call isolation of the vein. You still leave the vein firing, but you cauterize all around the vein so that the electricity from the vein doesn't leave the vein anymore, doesn't go into the left atrium. So again, if we know that it's coming out from discharges from the pulmonary vein, we will isolate or eliminate those discharges. So this is how it's done. So we put this lasso catheter, this circular catheter, inside the pulmonary vein and identify that vein, there's a lot of electrical activity coming from the vein, and essentially point by point go cauterizing all around the mouth of that vein. And what that does is causes a scar tissue to form in an organized fashion. So you're going to have a rim of scar tissue around the pulmonary vein. Scar tissue does not conduct electricity, unlike the rest of the heart tissue, and this will prevent electricity from going into the heart and getting one into AFib. So it blocks, essentially, at the line where we cauterize, there will be block of the electrical activity. There's two ways of doing it. We can do radiofrequency ablation, where we go point by point cauterizing all around that vein, or cryo balloon, where you freeze the tissue to very cold temperatures and you create immediately that rim of scar tissue around the vein. Because this procedure, the anatomy of the left atrium is complex, and initially this procedure is being done using primarily X-ray fluoroscopy to perform it, and patients and staff, physicians were getting very high radiation exposure. This mapping systems were developed. The mapping systems allow us to do this procedure minimizing fluoroscopy, sometimes eliminating fluoroscopy, and also to help us navigate the anatomy of the left atrium. So this is a standard procedure for us here, where what we have is, I've done a venogram, so I have on the background you can see the left atrium. We then used what's called FAM mapping, which is the computer remembers everywhere the catheter has been, and it creates this 3D shell of the left atrium. And then after that, we go around the pulmonary veins and cauterize it. So here you can see these big circles, taking 2 veins at a time, and those are the areas that I've cauterized, have ablated to eliminate the firing from the veins. It can also be done with the cryo balloon. So you go and position this balloon into the pulmonary vein. It gets really cold, and hopefully that will create that rim of scar tissue that we want. This is an example of the procedure. We put this mapping catheters always deep in the pulmonary vein. We're measuring the electricity inside the vein in these catheters. And there's many components of the electrical activity here, but what you see, there's this sharp component, which initially is early. As we cauterize, it has been pushed back to here. So now there's delay in the activation, and with further ablation, you see this sharp component is completely gone. This vein is now what we call isolated. This is another example where you see the sharp component here. So this first component is the atrial activation, the second one is the pulmonary vein. Now there's a delay, and then the pulmonary vein potential is completely gone, meaning that that vein is isolated. There's no more electrical activity in that vein. This is an example where the patient is in atrial fibrillation, and as the ablation is performed, the patient goes back to normal sinus rhythm. So does the procedure work? It works. It works better for patients with paroxysmal atrial fibrillation, healthier patients, than patients with persistent atrial fibrillation. Also, the more risk factors, more comorbidities one has, the less likely it is to work, unfortunately. But for the initial trials that they looked at, patients with paroxysmal atrial fibrillation, there was success rates of about 80 to 90%. Compared to, when you compare to drug therapy, you see how successful one is with medication. So at the end of 1 year, about 80% of the patients are back in AFib when you're just giving them drugs. This is another study from this group in Italy. They've probably performed more AFib ablation than anyone else in the world, and a success rate of about 80%. This is showing that there's a significant improvement in quality of life, so patients feel significantly better after this procedure. And also for some patients that have congestive heart failure, we have shown that there is a significant improvement in the ejection fraction. So the heart function can get better when you put these patients back into normal rhythm. This is the cryo balloon ablation cryo balloon trial. There is 70% success rate at the end of 1 year or 1 year and a half compared to 7% in drug therapy. And for centers that had performed more than 10 procedures, there's a 90% success rate. So this is showing the learning curve of that new procedure. So who are the candidates for atrial fibrillation ablation? Well, you have to be healthy enough for the procedure, of course. And I think the most important thing for me is always the patient symptomatic. I'm not going to do this procedure with someone that doesn't have any symptoms from AFib. The person needs to have symptoms. And again, very easy to determine if the patient is paroxysmal AFib. If they're in persistent AFib, oftentimes you're going to see me cardioverting them first. When I see them in clinic, we'll determine whether or not they are symptomatic from AFib. So when it comes to AFib, the important thing is that you need to understand that it's rarely a life-threatening disease. However, it's a recurring thing. So when someone develops AFib, that will decrease that patient's quality of life significantly. And I mean, we have patients that are afraid of leaving home because they are afraid that they're going to have a spell of AFib when they're not at home, how they're going to handle with it. So it really handicaps a lot of patients. When you're seeing someone with AFib, the things you need to think about is to decrease the frequency, duration, and severity of the spells of AFib. So we're going to use medications for this. In some patients, we're going to do the ablation to try to eliminate AFib. But I really think the most important thing is to reduce a stroke. It's a disaster to see a 65-year-old person have a stroke and be bedbound forever now because of a stroke that could have been prevented by medications or procedures today. And also very important is to reduce the risk of tachycardia-induced cardiomyopathy. If you leave someone in AFib going at 150 beats per minute for weeks and months, their heart will get weak. So AFib, to summarize, it's a highly prevalent condition. The way we're going to treat is all going to be based on the symptoms. Everybody needs to be on some strategy to decrease the risk of stroke, but then how we're going to treat past that point is going to be depending on how symptomatic one is. Atrial fibrillation ablation is effective. Success rates are very good. It can reduce or eliminate the symptoms in most patients. It reduces the risk of stroke as well and can significantly improve quality of life. And we have done a few of these over here. So, any questions?
Yes, radio frequency versus cryo. Why do you determine which gets one and which is the other?
Good question. So, radio frequency, you can do a lot more. There's a lot more. The ablation catheter, I can use it to do other types of ablation as well. So, for example, if someone has also what we call flutter, I can go in and do flutter ablation. And this is two diseases are often seen together. Or if someone has persistent AFib that I need to do more work than just the pulmonary veins, then I need the ablation catheter. The cryo balloon is only for the pulmonary veins. You can't do anything else. If I decide to use the cryo balloon catheter and the patient develops a flutter during the procedure, I need to open an ablation catheter to use for it as well. So I typically use the cryo balloon for the select patients that really have only AFib. And you probably see that they're going to be younger, healthier patients than the other patients I typically use the radio frequency. And truth is, probably 60% of the patients we've done ablations here have persistent AFib. So the cryo balloon catheter is not even indicated for that. It's a good tool for the rare patients that have only AFib. Or not rare, uncommon patients, at least for us. Any other questions?
Can you tell them about the AFib clinic?
Oh, I'm sorry, that's very important. So we have opened an AFib clinic here, along with the hospital. We have put a lot of effort into creating a lot of educational material for our patients, educating staff of the hospital, the hospitalist group, the emergency room physicians. So the AFib clinic is going to be a tool for education of our patients, making sure the patient is getting exactly the best treatment. So what we'll get is when someone is being discharged, if the physician wants, they can simply call the AFib clinic and schedule an appointment with us at any time so that we'll see the patient, decide on anticoagulation, decide on is the patient a candidate for ablation or treatment options available. Really not only just educate the patient, but make sure the patient is on the correct treatment for AFib. And what is the phone number for the AFib clinic?
939-7936. I'll make some index card and pass it out later.
Okay.
What determines what size sheet you use when you do the procedure?
The cryo balloon is always that gigantic 14 French. The other just radiofrequency ablation, I have to use 3 8 Frenches. Occasionally, we use intracardiac echo. Intracardiac echo is a second 10 French. And so that's why the standard radiofrequency procedure will be only 3 sheaths in the 3 8 French sheaths in the right femoral vein, in the left femoral vein. If I use intracardiac echo, then there will be another 10 French on the other side. And if it's cryo balloon, always you use both groins, and I'll have a 14 French on one side and 2 8 Frenches on the other side.